3, 2, 1, go.
Very good evening to my dear MOS members and the ophthalmic fraternity Pan India who have joined for today's most interesting webinar. Maharashtra Ophthalmological Society Academic Committee. We have 21 committees, out of which the academic committee, with the consultation with Dr. Santosh Honavar, we are coming up with the first of this series on preferred practice guidelines about PTOSIS. So we have none other than the chief editor of IGO, Dr. Santosh Honavar, a good friend of mine, humble to the core, who is going to guide us through all this. And later on, if the sponsorship permits, we are definitely going to come out with a booklet. Will be distributed Pan Maharashtra and Pan India if we have enough sponsorship. With us today, we have Professor Usha Singh. She is the professor at PGI Chandigarh. Welcome, ma'am. Dr. Ramesh Murthy, our own in-house international faculty, and Dr. Adit Gupta, who is going to moderate the session. Dr. Ramesh Murthy, Dr. Usha Singh, and Dr. Santosh Honavar will be the Dr. Santosh Honavar is going to be the speaker come panelist, and this Dr. Ramesh Murthy and Dr. Usha Singh is going to be part of the panel discussion. My friend Dr. Rajesh Joshi, the honorary secretary, is the backbone of our association, very much there, and my treasurer friend Dr. Rajiv Mundra, he is also very much with us. So welcome all of you, and let's have a great evening together. Over to you, Adit, for further discussion.
Yes. Thank you, Taswala sir, for this wonderful opportunity and a program. We also thank Team Maharashtra Ophthalmological Society for taking such wonderful initiatives, especially webinars have a far-reaching impact on people because they can attend it from anywhere, especially PG students who are so short of time and they cannot physically be present over everywhere. So my job will be to moderate this session. I will introduce all the speakers and the panelists first. Everyone knows Dr. Santosh Honavar sir. He needs no introduction, but I will give you a separate, different take on my introduction to him. He is obviously a very well-established ocular oncologist who has been instrumental in developing this subspecialty in India. You can also call him as the father of ocular oncology in India and maybe in the whole of Asian region. He was the one to establish the ocular oncology and ophthalmic plastic surgery services at LV Prasad, after which now he heads the oculoplasty and oncology services at Center for Sight and also heads the CFS education program. He has been the recipient of multiple awards, notably the Shanti Swarup Bhatnagar Award given by the Government of India, the Jerry Shields Award, and the Lifetime Achievement Award by the American Academy of Ophthalmology. And currently, he is the editor of IGO and has taken IGO to new heights. I relate him to a modern day Dronacharya because a lot of us have learned from him. We are modern day Eklavyas who have learned from him by just observing him and attending his lectures and silently observing his surgeries and impeccable surgical videos. So I would relate him to a modern day Dronacharya who is impacting a lot of lives and inspiring people to take on the field of oculoplastics. Next, we have our first panelist, Professor Usha Singh. She has been instrumental in developing this field in Northern India. She is currently the professor in Department of Ophthalmology and the head of Oculoplastics and Retinoblastoma Service. She is currently elected Vice President of the Oculoplastics Organization of India and ex-president of the Chandigarh Ophthalmological Society and has held multiple executive positions in different ophthalmological societies. She is also the life member of International Society of Ocular Oncology and recipient of the Best Paper Award in the European Society of Ophthalmology. In 2019, she was conferred the Woman Doctor of Chandigarh Award by the Bharat Vikas Parishad. Last but not the least, Dr. Ramesh Murthy is a consultant oculoplastic and squint surgeon and has his own Access Eye Clinic and also is a consultant at Dinanath Mangeshkar Hospital, Pune. He is academically very active and has more than 130 publications and 37 awards to his name. He has been the editor of Pune Ophthalmological Society Journal, and is currently the section editor of ocular oncology in IJO. Without much ado, I would like to invite Dr. Santosh Honawar to give us his talk on preferred practice patterns in PTOSIS surgery. He will be speaking for approximately 45 minutes, after which there will be a 15-minute question and answer discussion time. Over to you, Dr. Santosh.
Thank you so much, Adit, for the kind words. And I thank Maharashtra Ophthalmological Society, specifically President Jignesh Taswala, Ragini Parekh, Rajesh, and also Dr. Mundara for the kind invitation. I will be talking on PTOSIS preferred pattern. Whenever you have a patient of PTOSIS sitting in front of you, you have to ask yourself and answer these specific questions. What is the severity of PTOSIS? What is the etiology of PTOSIS? Is there any complicating factor that is associated with it? What surgery am I likely to perform, or I am likely to perform any surgery or not at all? Is surgery going to be safe for the patient? And what is the expected outcome? Am I going to correct PTOSIS completely? Am I going to leave the patient little undercorrected? How am I going to explain all that to the patient? For that, you have to start with a clear history, age of onset, mode of onset. I'm not going to go into the details of all this, but just a snapshot of what all you would ask in the history. Laterality as the patient perceives it. Maybe it is bilateral, but the patient perceives it as unilateral ptosis. Diurnal variation, progression if it were to be acquired ptosis, history of trauma or prior surgery, use of any medications, because steroids can cause ptosis, we all know that, periocular and systemic symptoms. There could also be a family history of ptosis, as is evident in these two families. Mother and the child, and the father and the child have ptosis. Mother here on the right side has unilateral ptosis, whereas the child has bilateral ptosis, whereas on the left side, both the father and the child have bilateral ptosis. Review of old photographs is very useful. If you look at this particular set of pictures, you find that the patient has ptosis, which is of acquired nature. When she was born, when she was younger, she never had ptosis, and possibly at about 20 years of age, she started developing subtle ptosis, which increased over a period of time. So you can fix this as acquired ptosis. Now, as we talk to the patient, we also look at the patient's face very subtly and see how the patient is interacting with you. Is the patient using frontalis? Does the patient have a head posture? As the patient walks into the clinic, you have to look at all that, and also the facial features of the patient. Is the ptosis variable as the patient speaks to you? As the patient animates, does the ptosis change? Possibly then the patient has synkinetic ptosis. And also look at the expression of the patient. If the patient has zero expression with bilateral ptosis, possibly you're leading to the diagnosis of myopathy. Then we go on to crucial information, looking at the face, palpable fissure in 3 gazes. Down gaze measurement is important to differentiate acquired from congenital ptosis. MRD 1, 2, and 3, herrings, margin limbal distance, amount of ptosis, which is categorized as 2, 3, 4, mild, moderate, severe, levator action classified as poor, fair, and good. There are many other ways to categorize levator action, but this is the standard 3 to 4, 5 to 7, and more than 7. Frontalis action, anything more than 10 is considered normal. MRD1, MRD2, and MRD3 concepts you all know. MRD1 is the measure of ptosis, whereas MRD2 actually measures the position of the lower lid. Sometimes the vertical palpable fissure may be equal in the right eye and the left eye, but the patient may still have ptosis. That may be compensated by lower lid retraction. So it is essential that you measure MRD2. MRD3 is lid margin to the lower limbal distance. This is mainly a useful measure in patients who have elevation deficit, unilateral elevation deficit. You also measure margin crease distance to symmetrize it, because the goal of ptosis surgery is not just symmetrization of the lid position, but also the lid crease has to be symmetrized. You look at the tarsal platform show, and that also needs to be symmetrized if the patient is cosmetically concerned about it. Look at the skin quality. If the patient has dermatocalcinosis or stigma of blepharochalasis, then you might have to do a blepharoplasty along with your ptosis surgery so that the patient gets the desired skin quality. Look at vertical tarsal height, specifically if you're considering Fastenal Savard procedure. Note the element of lower lid retraction. lag of thalmus and orbicularis function, and also vertical lid height. Vertical lid height is an indirect measure of postoperative lag of thalmus. Now, specific examinations would also include synkinesis, which is quantified as less than 2, which is mild, 2 to 5, which is moderate, more than 5 is severe. It is also quantified in the manner that if the patient from ptotic position can lift to non-ptotic position, that is considered mild synkinesis. But if the lid lifts up to the limbus, then it is considered moderate synkinesis. If the lid on maximal synkinetic movement lifts beyond the limbus to show sclera, scleral show, then that is severe synkinesis. Also categorize ocular motility, specifically vertical motility. Look at strabismus, and specific attention you should pay to pseudotosis as well. Now, drug tests in ptosis are important. Phenylephrine test is important because if you have phenylephrine test positive, then you can consider the patient for mullerectomy. Phenylephrine test is simply done by using either 2.5, 5, or 10. All these three are used in the literature. 1 drop every minute for 3 minutes, and following the 2 minutes following the last drop, that is 5 minutes from the initiation of the first drop, you measure the amount of palpebral fissure and the MRD, and then it is positive if the lid lifts more than 2 millimeter. But then depending on how high the lid lifts after phenylephrine test, you can categorize how much mullerectomy you want to do. Also, if a patient has ptosis and anisocoria, meiosis, anisocoria, poor pupillary dilatation, inverse ptosis, that is higher position of the lower lid, enophthalmos and anhidrosis, you should consider Horner syndrome, and there is a drug test algorithm for Horner syndrome, details of which I won't go, but currently aprecolindin can also be used for categorization of Horner syndrome. Pseudotosis, one way of looking at pseudotosis is lack of support, as in this patient who has a prosthetic eye because of lack of support to the lid and also atrophy of the fat, there could be an element of ptosis, which can get corrected if the prosthesis is built up a little more or if a ptosis shelf is given. But the other way of looking at pseudotosis is when the patient has hypotropia. This patient has severe ptosis in the left eye and a monocular elevation deficit, as you see here. When you ask this patient to fixate with the right eye, obviously there won't be any change in ptosis in the left eye. But if the patient tries to fixate with the left eye, hypotropia gets corrected partially and the lid lifts partially up. So in such patients, it's always mandatory to correct hypotropia first and then do ptosis surgery, so that you have eliminated the component of pseudotosis and you're correcting only true ptosis. Coming to management issues, when to operate a patient with ptosis. If a child were to come to you newborn in the first 3 or 4 weeks of life, would you operate at that stage? Possibly not. If it's bilaterally symmetrical ptosis or nearly symmetrical ptosis, you wouldn't want to operate at that age. But as the child starts sitting up, maybe or at the age of about 3 to 6 months, you would assess the child for head posture, and if the child has severe head posture, possibly you would operate. But if a child has unilateral severe ptosis of this sort, as soon as the child is fit for anesthesia, roughly at about 3 months of age, would you operate? And the best form of surgery that is done is a temporary tarsofrontal sling, which is a reversible sling. In which situation you would do a suture sling, which is completely reversible. When the child is older, you reverse the sling, reassess the amount of ptosis, reassess levator action, and then do a permanent procedure at about 6 to 7 years of age. So here the goal is only to lift the lid enough to expose the pupillary axis. I'll show you a video clip of doing a temporary tarsofrontal sling.
This video illustrates congenital ptosis correction by tarsofrontal sling surgery.
Here I use Ethibond 30 or 40. It's a very friendly suture. Ethibond is polybutyrate coated braided polyester, which has polybutyrate coating, which makes it biocompatible, and braiding of polyester makes it stronger. 30 is used for children who are about 3 years of age. 40 is used between say 3 months to 3 years of age. It's a triangle sling where 2 points are marked about 8 millimeter apart in the middle of the tarsus, and a suprabro incision is made, which is about 5 millimeter in span, about 10 to 12 millimeter above the bro or supraorbital margin. and then a subcutaneous pocket is created, which is for the distance of about 10 to 12 millimeter, so that you can bury the sling later. Then you use a ethibond suture. Here we're using a 3-0 ethibond suture in the pre-tarsal plane, making sure that it hasn't come out on the other side. Obviously, you should not perforate the tarsus. This is only epitarsal or pre-tarsal. And the same point is used to enter a free needle, which now traverses suborbicularis, under the septum, under the brow, and comes out through the forehead incision, right in the middle of the forehead incision. And the triangle is completed by doing the same maneuver from the opposite side. So now we have completed the triangle. Then the suture is tied with enough tightness to get the desired correction. It looks overcorrected because we are pulling on the suture to tie the knot, but basically you want to leave it about a millimeter lower than the limbus, or even lower than that. The idea is not cosmetic here. Idea is just to expose the pupillary axis so the child can receive amblyopia treatment. Knot is made slightly larger so that it doesn't cut through, and there is fibrosis around this large knot that we have created. And not just the end of that, you actually pass the suture under the subcutaneous pocket and come out about 12 to 15 millimeter higher in an oblique direction. This nicely buries the cut edge of the sling material, so that the chance of suture granuloma or knot granuloma is much lower. After I modified this technique by incorporating this particular step, my complication of knot granuloma has drastically reduced. Now you simply suture the forehead incision and cut the sling material after pulling it slightly. So sling would be lying, the cut end would be lying somewhere there, nicely and deeply buried in the skin muscle plane. So obviously this has a much lower chance of sling granuloma. Now a reverse frost suture is mandatory so that the cornea remains protected while the child recovers, and after a week you can remove the reverse frost suture. That was a suture sling. Now these children respond well to suture sling. This child has correction of chin elevation following suture sling, and obviously he is ready for amblyopia treatment at that time. Going on to other cases, what surgery would you perform in a given patient with ptosis? There is a range of surgery starting from molarectomy to tarsofrontal sling, and let's consider each of this. Right. So these are clinical situations. What is the preferred surgery for a patient with mild ptosis with good levator action? Anybody who has about 8, 10, 11 millimeter levator action, 2 millimeter or 1 millimeter ptosis, what is the preferred surgery? First step that you would perform in such patients is a phenylephrine test. Molarectomy was described by Putterman, and he postulated that if you were to do about 8.5 millimeter of molarectomy from the conjunctival approach using a Putterman's molarectomy clamp, then you would correct ptosis if by phenylephrine test the desired height has been achieved. What I meant to say is that if the ptosis is 2 millimeter and by using phenylephrine the ptosis has got fully corrected, then Putterman suggests that you do 8.5 millimeter molarectomy. You add or deduct 1 millimeter for every 0.5 millimeter under or overcorrection. So the range of molarectomy that Putterman suggested was ranging from 6.5 to 9.5 millimeter. There are many other algorithms, whichever you think would work in your hands, you can use. But this is one of the standard algorithms. That is why I'm showing it. But after that, there have been several other modifications, including tarsectomy, etc. But this is something that is standard. 8.5 millimeter molarectomy for a patient who achieves complete correction with installation of phenylephrine. Now for patients where phenylephrine test is negative or is suboptimal, then you would do Fassler-Savart procedure. The indications for Fassler-Savart procedure are 2 millimeter ptosis and anything more than 10 millimeter levator action. And the standard thumb rule is that for every millimeter of ptosis, you resect 2 millimeter of the tarsus. Considerations are that the patient should have adequate tarsal height. For example, if a patient has 2 millimeter ptosis and has 8 millimeter vertical tarsal height, then you would be resecting 4 millimeter of the tarsus and you would still be left with 4 millimeter of residual tarsus. So aim for at least 4 millimeter of residual tarsus. If a patient has 6 millimeter vertical tarsal height, the maximum amount of ptosis you can correct would just be 1 millimeter, because for every millimeter of ptosis, you have to excise 4 millimeter. If you excise 2 millimeter, if you excise 2 millimeter, then you'd be left with 4 millimeter. So just to repeat, if you have 8 millimeter of vertical tarsal height, you can correct up to 2 millimeter of ptosis. But if the vertical tarsal height is suboptimal, say 6 or 7 millimeter, then your span or range of correction is limited, because you have to leave at least 4 millimeter of vertical tarsal height intact. This is a video clip that shows fascicular cervical procedure. You can perform it under local anesthesia.
Correction is desired and test is negative. Marked on the tarsal.
This is the central part that we mark, and then 3 sutures are passed at the edge of the folded tarsus. This is 40 silk suture. Some surgeons prefer not to use sutures. Then we ask the patient to look down, pass a suture right from the superior fornix to exit just short of the lid margin. 3 such sutures, again, the purpose of which I'll show you a little later. Similar suture on the medial side and a similar suture on the lateral side as well. When you pass the lateral suture, make sure that you don't pass it through the palpebral lobe of the lacrimal gland, otherwise you'll have brisk bleeding. So these 3 sutures are passed, so you have a set of 2 sutures. Now you mark the amount of excision which is pre-calculated on the tarsal plate, either using a marker pen or a bipolar cautery. Then that is run parallel to the lid margin, tapering off medially and laterally to maintain the lid contour. You should not have a squarish contour. So basically you taper the mark parallel to the existing lid margin, so it tapers off medially and laterally. The amount of excision is 4 millimeter in the center, and it is tapering off medially and laterally. Then you use a monopolar electrode or a Bartpacker knife for full thickness tarsal incision. Using monopolar electrode minimizes bleeding, so you can visualize exactly what you're doing. That is the gape that you see when you're gone full thickness through the tarsus. Then you go and match the same gape all through the span of the tarsus. And then you excise it full thickness after lifting it off from the lid guard. So you're actually excising 4 millimeter of the tarsus and tarsal conjunctiva and 4 more millimeter of palpebral conjunctiva, because it is folded. So your measurement is on the tarsus, but you're actually excising an equal amount or nearly equal amount of palpebral conjunctiva as well. Now the second set of sutures would come in play now. You mark the position of the lid margin, margin crease distance or whatever that you've already calculated, or the pre-existing lid crease. Exteriorize a plain catgut suture, which is 60 plain catgut suture. Take it through the lid and suture the residual conjunctiva to the residual tarsus. So when you use the second set of sutures, you can pull up the residual conjunctiva from the fornix, so that you don't have to keep digging into the fornix to get the residual conjunctiva. And when you suture it through the tarsus, make it buried through the inner lip of the tarsus, not through the outer lip, and exteriorize the other end of the suture and tie it on the skin side. Suppose the suture does not dissolve in 1 week, you can always cut the knots and pull it out. And if you fear that you are not completely buried in terms of when you pass the suture, then you can always use a bandage contact lens for the 1 week or 10 days post-operative period, so that there is no corneal abrasion. Results of fascicular cervet are fairly good. You can actually see that the lid crease also symmetrizes, which is actually considered a little difficult in fascicular cervet, but I have observed that lid crease symmetrizes in a majority of patients when you do fascicular cervet procedure. One more example of a patient where you can see that her lid crease in the right eye has symmetrized without having to do anything specifically to form the lid crease. It symmetrizes. When not to do fascicular servet in patients who have lash ptosis are specific contraindications or relative contraindications for fascicular servet. Suppose that lashes are supposed to point up like that. If the lashes are horizontal or are pointing down, then posterior approach ptosis surgery of any sort may further worsen the lash ptosis, and lashes may come in the pupillary axis, thus causing diffraction effect and vision related symptoms. So fascicular servet ideally should not be done in patients who have lash ptosis. This is again a patient where the lashes are pointing down in the left eye. Although she's a very good candidate for fascicular servet, I would still prefer anterior approach, because if you were to do fascicular servet procedure, then the lash ptosis may worsen. Going on to levator surgery, we have 5 types of levator surgery: levator reattachment, plication, resection. Whitnell sling is a form of levator resection, and levator excision. Now, levator resection is specifically for patients who have congenital ptosis, where the ptosis is more than 2 millimeter and levator action is more than 4 millimeter. But you can always extend or individualize indications. There are 2 ways of doing levator resection. One is conjunctival approach and the other is skin approach. Conjunctival approach is ideal for patients who have say 2 or 3 millimeter of ptosis with 6 to 7 millimeter levator action. It works beautifully well in patients who already have a lid crease. It's a very nice procedure. Only thing is that the anatomy is slightly difficult for somebody who's trained in skin approach. So you might have to kind of do it a couple of times to get a hang of it, but it's a beautiful procedure. Whereas if a patient has slightly worse ptosis, say 3, 4, 5 millimeter ptosis with 4 to 5 millimeter or 6 millimeter levator action with no lid crease at all, then skin approach is preferred, because it's slightly difficult to kind of give a nice lid crease, symmetrical, deeper lid crease, dynamic lid crease by the conjunctival approach. Now, how much to resect? There are many rules. Beard and Berkey's rules are often referred to, but if you go by the Beard's nomogram, then there are many variables. One variable is ptosis, the second variable is levator action, and the third variable itself is the amount of resection. Now, amount of resection depends on the pliability of the levator aponeurosis. If it is fibrotic, it may not stretch, and if it is not fibrotic, it may stretch too much. And depending on how much the surgeon is actually pulling the levator aponeurosis, many factors, and where exactly have you disinserted the levator. There are too many variables with the Beard's rule, so it has a suboptimal outcome. But where to place the suture, there is no controversy. You can place the suture under the Whitnell's ligament, above the Whitnell's ligament, or through the Whitnell's ligament. Now, conventionally, if a patient has about say 6-7 millimeter levator action, you place the suture under the Whitnell's ligament and tie the suture with enough tightness to achieve the correction of your choice on the table. If you pass the suture above the Whitnell's ligament, then you're actually aiming at supramaximal resection. That means that the patient has severe ptosis and poor levator action. You are doing this procedure as an alternative for tarsofrontal sling. Then you place the suture high above the Whitnell's ligament. If you place the suture through the Whitnell's ligament without cutting the horns, then that becomes Whitnell's sling. This is also performed in patients who have poor levator action and severe ptosis as an alternative to performing unilateral tarsofrontal sling, which may not work in patients who don't have a frontalis action preoperatively or an amblyopia and may not have enough stimulus to use the frontalis muscle. So conventionally, it is passed under the Whitnell's ligament, and there is a scope to pass it through the Whitnell's ligament or above the Whitnell's ligament to place the lid at a particular height. So Berkey's rules are very clear. If the levator action is 6 to 7 millimeter, you can say 7 millimeter, you place the lid exactly where you want it to be postoperatively. This is intraoperative placement of the eyelid. In congenital ptosis, that's what Berkey described, under general anesthesia, but you can extrapolate it for local anesthesia as well if you're given a frontal block or if the patient doesn't have too much of edema. And you can extrapolate it to any sort of ptosis. Basically, you should understand that if the levator action is about 6 to 7 millimeter, you leave it exactly where you want it to be postoperatively, because such lids neither droop nor go higher than where you have left it. If a patient has levator action worse than that, say 4 to 5 millimeter levator action, you overcorrect on the table. If the levator action is much worse, you overcorrect further, you leave it at the upper limbus. If the levator action is better, you start undercorrecting because such slits lift postoperatively. If the levator action is much better, your on-table correction would be slightly lower, because you assume that if the levator action is better, they lift postoperatively. If the levator action is worse, they droop postoperatively. But if the levator action is in the range of about 6, 7, 8 millimeter, then they neither lift nor droop, unless there is a major mishap such as suture being broken. This is the video clip of levator resection. You first start the surgery by marking the intended position of the skin incision, which is the position of the lid crease, which is symmetrical to the contralateral side. If it's bilateral ptosis, you take about 7 to 8 millimeter as the lid crease height. Then skin incision and superficial orbicularis incision, we're using a monopolar electrode. Suborbicularis dissection to expose the orbital septum. Change in color indicates change in plane. You can see from pink to yellowish change in color indicates that we have gone and exposed the orbital septum. Then inferiorly, you do the same suborbicularis dissection to expose the anterior surface of the tarsal plate. All you need to expose is the middle of the tarsus, wherever that could be. About 4 millimeter of tarsal surface needs to be exposed for you to pass the suture. Then I would do this step. Some surgeons don't prefer it. I would actually inject xylocaine, quite a bit of it, under the conjunctiva to create a plane of cleavage between the conjunctiva molars and the levator aponeurosis. Then you flip the lid back and pass a set of 3 sutures through the levator aponeurosis partial thickness. This helps you tent up the aponeurosis and helps you disinsert the aponeurosis without the risk of causing a buttonhole. It also gives you better hemostasis. That is how you disinsert it, create a slope, and you eliminate the slope. So basically, perpendicularity of levator in relationship to the conjunctiva indicates that you have gone full thickness. Then you further dissect it just a little bit before you put in a dry cotton tipped applicator and peel the levator off the conjunctiva and molars. This is relatively bloodless. Then you come back to the anterior surface, open up the orbital septum, expose the fat pad. One of the current concepts is to recess the orbital septum, including the fat pad. That is also possible. But in majority of patients, you need to open up the orbital septum. Go as high as to visualize the Whitnell's ligament or broadening of the levator, as you see here. That indicates the putative position of Whitnell's, even if the Whitnell's is not well demarcated in a given patient. Cut the horns very gently, not to harm the Whitnell's ligament, which is the fulcrum for the levator, and pass suture through the tarsal plate, not to go full thickness. Get a good purchase over the tarsus and pass the suture. Double arm 6-O-proline is what I use. Vicryl is also used. Dexon is also used, depending on the surgeon's choice. Medial suture and the lateral suture are slightly oblique to get the right contour. All are double arm sutures passed right under the Whitnell's ligament. That's the third suture. Again, slightly oblique. The medial and lateral sutures are slightly oblique. Double armed again. Then you tie each suture to achieve the contour and the height of your choice. So each suture is tied separately to achieve your preoperatively determined position. Burke's rule is what we follow. And then finally, you form the lid crease. Lid crease is formed by suturing orbicularis to the stump of the levator to the orbicularis again. And the skin incision is closed using 6-O-proline continuous suture. So patients do well with levator resection. As you see here, they get a lid crease. And in patients who have severe ptosis, unilateral ptosis with poor levator action, like this patient has severe ptosis, pupil is covered completely, but she hardly has any frontalis action because she's a deeply amblyopic eye with 636 vision. and the patient does not have any inducement to use the frontalis because she has poor vision in that eye. She is habituated to not to use frontalis at all. So such patients sling may not work well. So you might have to do a supramaximal resection or Whitnell sling. This is again a patient with poor levator action, severe ptosis, doing well with Whitnell sling. But the only problem with Whitnell sling or supramaximal resection is that there is severe downgaze asymmetry and also higher risk of lag of thermus. So for patients who have unilateral severe ptosis with poor levator action, then or bilateral severe ptosis with poor levator action, then the surgery of choice is tarsofrontal sling. Now, what is the ideal sling material? You have these qualities for an ideal sling material. It should be biocompatible, non-biodegradable, biointegrable, or reversible and adjustable. So biointegrability goes against it being reversible and adjustable. So if you have a biointegrable material such as fasciolata, then there is no possibility of reversing or adjusting. Whereas if you have a non-biointegrable material such as silicone, it is both reversible as well as adjustable. Flexibility is one more criteria that we look for. It should be easily available and should provide easy handling. Now, this is the list of sling materials that are available. What is classic and still considered the gold standard is fasciolata, whereas what has come up in the last couple of decades and has become much favored material is silicone. Silicone, being non-biointegrable, as I said, is reversible and adjustable, which is a very good quality because no sling can be permanent. And if you're doing it in a stage where the child is still growing up, maybe at 6 years of age, you cannot rely on fasciolata to maintain the lid height and symmetry when the child grows up. So if you have a reversible adjustable material, you can redo the sling or simply adjust the sling to achieve a particular height. Silicone can be adjusted even decades after the surgery was done. I've done that myself. So it is something that you can leave in there and adjust as the child grows up. The way to perform sling, I'll show you in the form of a video clip.
This video illustrates 800 microns, 8 millimeters apart. Round up.
See, the supratarsal markings are about 8 millimeters apart. Medial and lateral suprabrow incisions are exactly in relationship to the medial canthus and the lateral canthus respectively. And the central suprabrow incision is about 10 to 12 millimeter above the superior orbital margin, parallel to the epitarsal incision. A silk suture is passed through the lid margin to stabilize it. A lid guard is placed. Epitarsal incision is made through skin orbicularis, which is a very superficial scratch incision, not to injure the tarsus. Stab incisions through suprabrow, medial and lateral. And the central forehead incision is made very carefully not to damage the frontalis, and a subcutaneous pocket is already created. This is a sling, 900 micron needle, 800 micron sling, atraumatic steel needle bent to the contour of your choice, passed from the central forehead incision to lateral or medial suprabrow incision, then epitarsal passage, making sure that you haven't gone full thickness through the tarsals, which can accidentally happen. Reverse direction, suborbicularis under the septum, under the brow, and comes out through the medial suprabrow incision. From the medial suprabrow incision, again coming back to the central forehead incision to complete the pentagon. And then you pass the ends of the sling through a 1300 micron silicone sleeve. Unload the sleeve of the artery forceps and tie the sling with enough tightness to achieve the desired height and contour. Bunching of tissues is natural because you have shortened the lid, and that will normalize over a period of time. Lock the sleeve to the sling using a 6-proline suture, and bury the sling along with the sleeve under the subcutaneous pocket that we have already created, and suture the central forehead incision and also medial and lateral suprabrow incision, and leave a reverse frost suture at the end of the procedure. It works well, as you see here. Of course, this child needs exotropia correction, but the lid height is very good. And the beauty of silicone is that it can work even in unilateral situations because it has some amount of flexibility. And even if the child doesn't use frontalis, it can maintain a particular height. This is one more patient with a unilateral silicone tarsofrontal sling. If a patient has bilateral asymmetrical ptosis, then you have to choose your procedure very carefully. This patient has 2 millimeter ptosis, 12 millimeter levator action in the right eye, and 3.5 millimeter ptosis and 5 millimeter levator action in the left eye. In such patients, you can do simultaneous surgery, but I would prefer, if it's asymmetrical, do a surgery in an eye where the results are not going to be as predictable as, say, a fast-Nala-Savart procedure. For example, levator resection is not very predictable. It is fairly predictable. So you do that first, ensure a stable lid position for the left eye. And once that happens after 3 or 6 months, then you do the right eye, because fast-Nala-Savart is extremely predictable. You get the height that you desire by doing this procedure. So finally, the patient is symmetrized both in terms of lid height as well as the lid crease. Now, for special situations such as synchronitic ptosis, elevator under action, and blepharophimosis, there are specific procedures. In patients who have synchronitic ptosis, mild synkinesis, treat ptosis alone. That's what I follow. If a patient has moderate synkinesis, then there is going to be a discussion. Discuss options to treat ptosis alone versus levator excision with sling. And if a patient has severe synkinesis, then you're bound to perform levator excision with unilateral or bilateral sling. Most aggressive way is to perform bilateral levator excision for unilateral synchronitic ptosis and bilateral sling. That's very aggressive. Short of that, you can do unilateral levator excision with bilateral sling to achieve down gaze symmetry, or the most conservative way of performing is to perform only levator excision on the involved side and do sling on the involved side.
Symmetrical with the contralateral eye at 8
This is a video clip of levator excision with sling. Here you begin with a skin incision. I'll skip these initial steps. That's the Whitnell's ligament. Beyond that, you pass a suture. Used a clamp here to excise about 18 to 20 millimeter length of the levator and cauterize it to retract into the orbit. Levator excision has to be complete. If you leave even a slip of levator fiber attached, then the patient may have residual synkinesis. That's the amount of excision that we are performing. Now, what is residual now? Just simply retracts into the orbit. Now we close the orbicularis with the stump of the levator that is left there. That is, of course, disconnected from its posterior aspect. That's to have some amount of fullness to the lid. Otherwise, when you excise levator, then the lid becomes fairly thin. Then you close this, and I would do a closed loop tarsofrontal sling. The procedure of tarsofrontal sling remains the same, but it's a closed loop sling. I prefer a closed loop sling than an open loop sling, because in an open loop sling, you have to suture the sling to the tarsus, which is not a very good idea if you are doing silicone. Of course, if you're doing facial ETA, then that is a totally different ballgame. So this procedure of sling is exactly the same as I had shown earlier. Now going quickly on to aponeurotic ptosis or acquired ptosis, you have involutional, myogenic, neurogenic, and mechanical. These are the examples of acquired ptosis. Now, involutional ptosis could be because of disinsertion, dehiscence, or degeneration. 3 Ds there. Disinsertion is when the levator aponeurosis disinserts from the tarsus. Dehiscence is when it is stretched. Degeneration can occur with either of these with fat infiltration. Involutional is not always equal to age-related. It could be caused by inflammation, trauma, mechanical aspects, and blepharochalasis. Now, bilaterality is a feature of involutional ptosis. It could be asymmetrical, but still bilateral. Other eye may have very mild ptosis. Unilateral aponeurotosis is possible with trauma, blepharochalasis, etc. Typically, it is worse on down gaze. Like this patient has bilateral involutional ptosis. When the patient looks down, he hardly has any palpebral fissure. So their main complaint is difficulty in reading, difficulty in climbing downstairs, because they don't have a palpebral fissure to speak of. At least the pupil doesn't fall into the palpebral fissure when they look down, and you see that near complete closure of the lid when the patient looks down. They can also have laxity of the lid, a very high lid crease, deep supratarsal sulcus, but they invariably have a very good levator action. They may also have canthal dehiscence, where the distance between the lateral limbus and the lateral canthus becomes almost equal to the distance between medial limbus and medial canthus, whereas the normal ratio for Asian Indians is about 3:2. The indications to operate could be cosmetic or functional. When the patient has the pupil covered, obviously that's a functional indication, whereas the pupil is exposed, or if a patient has no visual field defect, then that is purely a cosmetic indication. Here you can do levator reattachment, levator plication, or levator resection. Quickly, a video clip to show a levator reinsertion. Sorry, this is not playing. Anyway, that's all right. So basically, when you reinsert the levator, you pass the suture at a particular height and put it back on the surface of the tarsus. It works well, and you can see that when the patient looks down, the pupil is exposed as opposed to complete closure preoperatively. You can actually see the pupil exposed when the patient looks down. The idea of patient having a complete clear visual axis is achieved here with a reasonable amount of cosmesis. Levator plication is for dehiscence, and the thumb rule for levator plication is that for every 6 millimeter plication, you get about a millimeter of ptosis correction, and the maximum plicable amount of aponeurosis that is available is about 18 millimeters. So you can easily correct about 3 millimeter of ptosis by levator plication. Levator plication is again a predictable surgery. As you see here, this patient has undergone levator plication with symmetrization of the lid crease and a good lid height. Levator resection is performed in acquired ptosis if a patient has levator action less than 8 millimeter and also has fat infiltration. Myogenic ptosis, I won't get into the details, but you have to, there are many variants of myogenic ptosis, but the most common ones are chronic progressive external ophthalmoplegia and myasthenia gravis. You have to differentiate between the two. Tests for myasthenia are, we are all familiar with: fatigue test, Kogan lid pitch, enhancement, and orbicularis peak sign. But what is important to perform in the clinic is an ICE test, which is about 80% sensitivity and 98% specificity. Edrophonium is currently not available. So then you go on to neostigmine test. 1.5 milligram is injected in adults. And if the patient corrects at least more than 2 millimeter, then it is considered positive. If a combination of ICE test and neostigmine test are used, then the sensitivity and specificity is much higher. Apart from that, you can also test for anti-acetylcholine receptor antibodies, repeated nerve stimulus, single fiber electron myography, where decremental response of more than 20% is considered diagnostic. ICE test is a very elegant test that can be done right in the clinic. You can see bilateral ptosis corrected nearly fully, and in fact, left eye has gone into overcorrection following ICE test. I'll skip the video. Physically, ICE is applied for about 2 minutes, and the lid height is measured just after removal of the ICE. Now, in chronic progressive external ophthalmoplegia, you should understand that there are many systemic overlays which need to be elicited if a patient has CPO. And in patients with CPO, it is important to perform a peripheral muscle biopsy to look for red rag fibers, which confirms the diagnosis. And if that is confirmed, then you go on to explore for the possibility of Kearns-Sayre syndrome or extended ophthalmoplegia plus syndrome, so that you kind of elicit all the systemic features. In patients who have myasthenia gravis, medical management works. This is a patient after 1 month with pyridostigmine and oral steroids. You can see nice correction. Oral steroids in myasthenia is given in a pyramidal dose. That means you start giving in increasing dose. You start with 10 milligram and start going higher. And when the patient achieves good response, you stop there and very slowly reduce the dose. This is a patient with pyridostigmine, oral steroids, but for long-term treatment, he needs oral azathioprine patient of myasthenia gravis. Surgical management could be with crutch glasses, or in patients who have not responded to medications, or in patients with CPO, then you do what is called a safety enhanced surgery. Here you perform a lateral tarsorrhaphy, suture tarsorrhaphy as well, along with ptosis correction, and graded you release the FROS first and the suture tarsorrhaphy second. You can also elevate the position of the lower lid and also the upper lid, so that lag of thalamus is much less. For example, this is a patient where there is lower lid retraction and severe ptosis. We have lifted his upper lid and also done a little bit of lower lid retractor recession that has elevated the lower lid just about by a millimeter, millimeter and a half, whereas similar amount of upper lid correction has also been performed. So his pupil is exposed and the palpebral fissure height nearly remains the same while exposing his pupil completely. Complications of ptosis surgery are many, and you should try to avoid that. So in conclusion, I would say that assessment is the key to management of ptosis. Always set a goal for a particular patient, customize the goal. Perfection is an unreasonable goal in ptosis surgery. Explain that until the patient understands, demonstrate in front of a mirror, and make sure that the patients and the parents understand. Always follow a thumb rule if you're a beginner surgeon. Anticipate and preempt complications. And if you have a surprise under or overcorrection, don't wait for the tincture of time, but wait for about 3 or 4 days until the edema resolves, and then adjust within the first 1 week or 10 days so that the patient gets the desired lid height. Thank you so much.
Take it, sir. Don't make. Thank you very much, Dr. Santosh. Very well covered topic. Very well covered topic. So nicely done up. Each and every stop in the minutities you have covered it. So nice of you, boss. You have done due justice to the topic that has been given. I am sure it's going to be a gold standard for everybody to follow it up. So nice of you. Thank you very much. Over to you, Adit.
Yes, thank you, Dr. Honawar, for covering ptosis so eloquently and making us understand the minute details. Especially, it will be very helpful for postgraduates and general ophthalmologists. I will now request Dr. Usha Singh to comment and add her expertise to this topic, because I have seen and learned the first steps of ptosis surgery with her, and she also performs ptosis surgeries very frequently. So, ma'am, if you have any comments or if you have any thing to add on, we will be glad to hear that.
First of all, I'll congratulate Dr. Santosh, because he has really covered up every aspect of the ptosis surgery, the evaluation, ptosis surgery, counseling, everything. So, but at the end of it, I would like to say that each surgeon has their own way of, following their, the way of doing their surgery. So I rarely ever change my steps of surgery. And so we should stick to our surgery, because and over the years, a surgeon becomes very comfortable with his own techniques, and he knows the measurements because he's been observing his patients in the post-op period, on the table and in the post-op period. So they form their own algorithm, and they are very perfect in their surgery. So each one should follow their own. There are few things which Dr. Santosh has done differently, but I also do the same, like for example, the LPS resection, but I also achieve good results, but I never excise the horns, the lateral horns or the medial horns. And I never put my suture above the Wittners ligament. And I refrain from doing supramaximal resection because as we all know, that is associated with some post-op complications. And I think Dr. Adit has done a study with Dr. Milin, probably, on doing supramaximal excision, resection of the levator, and I'm sure he'll be able to add to it. And another thing which I wanted to say is measurement. Taking measurements and re-measurements in the preoperative period till we are very sure of our findings, and till we have decided what surgery has to be done. After that, the big task would be counseling the patient. So we should know what the patient wants whether they want just the aesthetic aspect or they want just the ptosis correction. Sometimes they want both, and I'm sure we can provide both of it to the patient. We can do resection and some skin excisions for the dermatocalluses. I'm sure we can achieve all that. So whatever the patient wants, we can do. But only thing, preoperatively, we need to be very clear. What is the role of brotosis? What is the role of senile, how this senile ptosis has come about? What is congenital ptosis? Wow. What would the patient see in the post-op for lid lag of thalamus, and what precautions to take sometimes? And another thing, sometimes what I feel that the patients, they're more very sensitive to the lid contour. Even we may have got a full correction of the lid height, but sometimes that little lid notch or something would be disturbing the patient. So I want to ask Dr. Santosh, how do you on the table make sure that you don't get all these lid notching, a little lateral flare, a little medial flare, So I would want you to share those fine tips with the audience.
Assess the lid contour on the table and then adjust the suture tightness accordingly, or even the suture placement. You have a lot of things to play with during surgery, but once you pass the suture and you tied it kind of becomes redo. Even if you call it adjustment in the postoperative period, it is a redo. So on the table, you have to keep adjusting till you are satisfied. For the medial and the lateral contour, I would pass the suture slightly obliquely on the tarsus. That gives me the best of contour. And I also observe the contour in the other eye. Some patients have a natural medial droop even in the so-called normal eye. So you leave it exactly that. You don't kind of normalize it according to your standards of normal, rather than symmetrize it as per the patient's other eye, which is already there. I would ask the patient, ask my assistant to look from the bottom and then see if there is any lid standoff that is more harmful than lag of thalamus. If the posterior lid margin doesn't touch the cornea, then that also needs to be corrected. And for the notch, I would pass the suture width to about 3 to 4 millimeter. If you pass a suture slightly less, say 2 millimeter, then it tends to leave an acute notch. If you pass the suture, say broader, say 5, 6 millimeter or 4 millimeter, then it makes a lid squarish in terms of contour. So ideal would be about 3 to 4 millimeter.
I agree with you, Dr. Santosh, because some of these patients, they have an anti-mongoloid slant also. So we need to take a note of it in the preoperative and try to make it, customize it as per the other eye. And also some of these patients, they have duriblephron. So while tightening, we need to take care of that it looks symmetrical. That's the only thing I wanted to add. And I think Dr. Ramesh Murthy can add his experience to all this.
I think one of the most important things is counseling the patient to tell them what to expect. We have to look at those fine things like lower lid position. Is there any inferior scleral show? And what is the expected outcome? And always try to bring down the expectations. Never promise 100%, because ptosis seems to be the most tricky surgery for me. Even the other day I have done a surgery, now I've ended with an overcorrection because somebody else gave the block and I have ended with an overcorrection. So, Dr. Santosh, what is the best time to correct an overcorrection? Now it's about a week.
Yeah, 5th to 6th day. Actually, I have started counseling in the last 12, 15 years. Every patient of ptosis, especially those who are adults, I would say that, okay, you will keep seeing you maybe the 3rd or 4th, 5th day. And if there is any under or overcorrection, we may simply adjust the suture. And I have been doing adjustment in the first postoperative week for a while now, several years. And believe me, I do it under topical anesthesia. Absolutely no block. Absolutely no block. I vouch for it. My fellows will vouch for it. Not even a single patient, adult patient, I have given a block. Everything comes absolutely smooth because it's topical anesthesia. There's no weight of anesthesia on the lid, and you can get the exact contour and the correction that you want if you adjust it within a week. I wait for the edema to resolve. I give them steroids injections, maybe a couple of dexamethasone injections, or even oral steroids for a very short period. Get the edema off their lid and then adjust.
Have you tried adjustable sutures? Sorry, pardon.
Yeah, adjustable sutures we had done in LVPA, we had done a study. But the problem that happened with adjustable sutures was that after adjustment, also patients went on to undercorrect or overcorrect. And that happened in about 20 or 30% of patients. Slight amount, but then, so that doesn't give you an additional advantage using adjustable sutures. But I would definitely want to use adjustable sutures and do use adjustable sutures in patients who are doing a recurrent or have a second surgery or a third surgery, or in patients who are very, very particular. There you can use adjustable sutures, but not in a routine case.
So what is the topical anesthesia used?
Topical anesthesia.
Paracaine drops. And Alphagan, of course, Alphagan blanches the field like anything. You have zero bleeding with Alphagan drops, couple of drops of Alphagan. Squint surgeons use it, you know that, right, Ramesh?
So paracaine on the skin, sir?
Paracaine, see, I just open the skin incision and after that you start using paracaine. Before that, you just use EMLA on the skin and that's all is required.
And then how do you suture the skin? Just under paracaine? Or you don't suture it, you let it
Adit, absolutely, Adit, they have zero sensation. They haven't even winced. Maybe because you have cut it recently, monopolar, maybe, that
Those
could
are
be,
probably.
It's possible to do it with that because what I have also done adjustment, I just open up the suture in the center and just put some few Xylocaine drops, and then if required, I just with a fine 30 gauge needle, I inject a little bit just in that local area and just tighten the suture. So it's possible. I'm sure I would like to try the paracaine alone. So I think it's possible.
I had one question. Very rarely do we do PTOSIS surgeries in Horner syndrome. First of all, Horner syndrome is not very common. But I recently encountered one young medical student who basically had acquired Horner syndrome because of a thoracic surgery. Now, if in your experience, Dr. Honava sir, how often have you operated on a patient having PTOSIS with Horner syndrome? Because first, it is very variable. Sometimes it is more obvious, sometimes it is less obvious. Secondly, what should be the preferred technique or choice of surgery to be utilized? Because I would assume mullerectomy goes out of question. Muller's is not going to act well in a case of Horner syndrome. And there is, means in literature as well, there are no fixed rules for any surgery. There's no protocol that which surgery is going to be better for a Horner syndrome case. And how are the outcomes if you have operated on a bunch of patients with Horner syndrome?
A bunch of patients, I must confess. I only remember 2 in the recent past. And one I did, I think, fastener severed. Second one was a levator plication. And both are doing reasonably well. They had about 2.5.
And is there variation post-op as well in their eyelid height, or they are stable with their eyelid height after the surgery?
Well, it varies by a millimeter, millimeter and a half sometimes. But well, I mean, they're fairly happy because they had issue with cosmesis and also, visual field issues, both being professionals. And what exactly did you do and how was your result?
I did a levator plication only because I didn't have much experience and I was going through literature.
Works well.
The patient is happy, but post-op, she also, since she is a medical student, she does mention that there is variation in her eyelid height, but 80% of the time she is happy with the outcome. So I did a levator plication as well. The second question was, we very commonly encounter severe disinsertion of the levator muscle in some of the old patients beyond the age of 60 with a very hollow sulcus and no eyelid crease. In these patients, in my limited experience, whenever I have gone in, I have seen that we would assume that the levator would be nice and we just fixate it and the eyelid will lift up magically. But there is a certain subset of patients where you cannot find the levator. It's all infiltrated with fat or it has become atrophic inside. So in such cases, even if you take a big bite of the levator or you go up to the Whitnall, sometimes the eyelid doesn't lift up to the required height or position. So have you had a similar experience where you find out that in such hollow sulcus patients, the levator turns out to be atrophic or they are severely infiltrated with fat?
Fat infiltration is fairly common and you have a challenge there because passing sutures becomes difficult. You can't pass sutures in the area where there is fat infiltration. But fortunately, I have been able to find the levator however atrophic it may be, and I have been able to pass the suture.
Okay.
And I unfortunately that video did not work, so I wanted to show you a finding which some of us don't recognize, until I started using a microscope to operate. Because of my neck issues, I had to shift to microscope from loop and naked eye surgery. I started recognizing that when the levator disinsert, it actually turns back and gets attached to the septum. So if it were to be like this on the tarsus, it flips back and gets attached to the septum. So if you find that junction of the levator getting attached to the septum, then you suddenly have an additional length of the aponeurosis. So that eliminates overcorrection in aponeurotic ptosis if you were to unroll it.
Okay.
I have a beautiful video showing how we unroll it and we use that additional length of aponeurosis. So the so-called Nirad's rule, Nirad didn't give his name to it, we gave his name to it. There is a nomogram where you attach the levator at a particular height, not always necessarily in the middle of the tarsus. Sometimes you hang it back to the upper 2/3 of the tarsus, or even at the upper edge of the tarsus, depending on the levator action. So you don't have to use any such tool. You simply reattach it and give an intraoperative height to the lid, and it works very well. So,
Dr. Santosh, how many times have you, what are the most challenging ptosis cases you have faced?
Marcus Gunn is the synkinetic ptosis is very challenging, very challenging, because however careful you are, they bring in some amount of synkinesis, and your measurement of levator action is off the mark. You measure it as 8 millimeter, 9 millimeter, but actually that may not be the real mark. It is a ptosis which doesn't get corrected with standard surgery. Say you might find the patient has 7-8 millimeter levator action, but if you do levator resection, they get undercorrection, right? So that is very challenging. Apart from that, of course, every ptosis is challenging. Every ptosis is individual. You can't, generalize ptosis surgery, but
yeah, I agree. So the most toughest case which I ever faced was a patient with a CPO. So this lady had senile ptosis superimposed on that other CPO part of it. And she had dermatocalluses, she had stretching of the LPS, and she desperately wanted correction. So we just did a limited LPS resection for her. But her son, who was much younger, he also had CPO, and he used to drive up and down the hill. So he had a lot of difficulty in clearing his visual axis. He wanted some kind of surgery. So we did sling for him and aiming at the undercorrection. So that was one, these mother and son, they were the two most challenging and cases which I faced. And sometimes even there is one more case of blepharocalysis in a young lady who had even LPS thinning. So that was another patient. I found it very challenging, but we could get the height in this young girl.
Nice discussion going on. Very nice inputs from each and every panelist, and of course Dr. Santosh also. Dr. Santosh, you are supposed to have a flight around 10. So would you like to take more questions, or we call it a day? Because very interesting discussion going on.
Absolutely. You can carry on. I'll take leave in the next 2 minutes.
Okay. Adit?
Yes.
Sir wants to take leave because he has a flight. Thank you to him for joining part of this show and making it so lively and wonderful. Of course, it's going to be, as Adit rightly said, very important for the PGs, and this be a thought of the preferred practice guidelines as prepared by the American Academy. We are in a similar line, we being the first society, a state society doing it, and your inputs, valuable inputs, and the way you have done it is fantastic. We are extremely thankful to you.
I didn't plug in literature to it. It is not that evidence-based preferred practice yet.
I know.
Plug in literature. If you have to come out with a booklet or something of that sort, then each of the points that we mentioned has to be plugged with evidence of adequate level of evidence,
Correct.
Class that you determine as a cutoff, and then it has to be passed through subject experts who have to give their inputs, and then it becomes a consensus statement. So it is a process that you have to go through. This was just a
Fine.
lecture. This was based on personal experience and the literature, but this is not evidence-based preferred practice.
Absolutely. Thanks a lot.
Thank you, sir.
Thank you, sir.
Thank you.
You can carry on with the discussion. Sorry, I had to drop out.
Thanks a lot once more.
Bye,
Thank
Vishnu.
you.
Bye. Thank
Thank
you.
I think we continue the discussion.
Bye, Raj.
We had had a very nice session now with Dr. Santosh. Sure, I think we can give you the leave for the time being for today's session. We wanted more of you, but definitely with your flight very much in time and you need to take a leave. Thanks a lot. Adit?
Yes.
Yeah, I think we can carry on the discussion with Madam and Ramesh before we sign off.
Yes. Dr. Ramesh, you also do a lot of pediatric ophthalmology, so you must be encountering a lot of pediatric ptosis, especially monocular elevation deficit and ptosis with amblyopia. Any specific tips or pearls regarding these cases, especially how do you manage amblyopia? Or first, do you try to convince the parents to get a ptosis surgery done or the other way around?
No, it's always convince the parents that amblyopia is a more severe problem, and ptosis being there, we always tell them that it is a functional surgery, not a cosmetic surgery. So half the work is done there, and then whatever aberration you might get post surgery, like any kind of under overcorrection, everything is acceptable because we are trying to correct the vision.
Because a lot of times we have noticed that after the ptosis is corrected, they don't follow up for the amblyopia treatment.
Exactly.
So that is one thing. How do you convince them to?
I tell them that ptosis is just one small part of the surgery. The main thing you have to do at home is to correct the amblyopia, doing patching, atropine, other treatment methods. So that is a must. And the second thing about monocular elevation deficit, what happens is, usually if the inferior rectus is tight and you do a recession of the inferior rectus, over time the muscle becomes more and more relaxed, and then you might have a overcorrection or some kind of situation like that. Or sometimes you might end up doing a muscle transposition. So over time, the results will improve, or it can change. The deviation go in the opposite way also. So ptosis should always be a little later if it is possible. And if it is not needed, then try to defer the ptosis for at least a minimum period of 6 months after you've done the muscle surgery, so that you don't end up making gross mistakes on both sides. So that is a very important thing, unless there is amblyopia, in which case we'll operate earlier.
And Usha madam was also mentioning about blepharochalesis. So I, in my personal experience, also find blepharochalesis ptosis one of the most challenging cases to deal with, because first, during the surgery, these blepharochalesis patients, since they are always inflamed, they bleed a lot. So I have seen that their orbicularis and levator and fat is very vascular. So whenever we are cutting, it bleeds a lot. Second, they always tend to have more edema and torrid post-operative course because of undue inflammation and swelling. So I always give them a course of steroids before and after the ptosis surgery as well. And third, their levator is very thin, that madam has already spoken about. Sometimes in spite of tightening it, you don't get the desired correction. Fourth, their tarsus is also very floppy and thin because of constant rubbing of eyes, because of allergies. Their tarsus is floppy. So getting a good tarsal bite and avoiding lid standoff also becomes a challenge. So madam has rightly said that blepharochalesis ptosis is one of the most challenging scenarios.
Yeah, but
very happy.
Patient I had managed, she was around 28 years old.
Young.
And I didn't find much bleeding though. But yes, tarsus was thin, it was floppy, and we got overcorrection on the next day. So we had to adjust the suture and and release the sutures. So it depends. I think it is I think surgeon skill related.
Yes.
And technique related, and so we have to be prepared for any post-op adjustments. I think if there is time, I could add some few points.
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
So when like Dr. Santosh uses this radio frequency to give the incision and even separate the LPS muscle, somehow I don't feel that comfortable with the radio frequency. I prefer the blade, because that is very stable in your hand and you know exactly where your, the depth of your incision is going. With the radio frequency, you could just cut through some of the many layers of, the orbicularis, and some of the LPS fibers also would get cut. So that is one difference. And of course, I never cut the horns in any patient. I mean, haven't done in so many years cutting the horn, medial horn or lateral horn. That is one thing. And another thing, what I feel, every LPS resection is a very, very highly skilled surgery, and it should be done under the microscope. And for that, we need to be familiar with the anatomy. So once we start doing it under the microscope, we start seeing every layer of the tissue, and you can know exactly what you're doing. And of course, it will you will correlate your results with the post-op results, and you'll know how right or how wrong you're going, or what adjustment you need to do in the subsequent cases. So doing under the microscope is very good. And of course, you have to control the bleeding, because it can form hematoma and then your field gets obscured. So you need to have a perfect control of the hemostasis. So these are few points, and I have already said I never go beyond the Whitnalls. So
Why don't you cut the horns, ma'am?
It's not necessary to cut the horns. Horns, like Dr. Santosh was saying, you need to cut them when you're doing supramaximal resection.
Correct.
So that means here the LPS action is not very good, but still you're doing a LPS resection. So you need to go much higher up beyond the Whitnalls. So that is one reason. But even for other cases or any where I'm putting the suture much higher up, I never cut the horns.
Okay.
When you're doing supramaximal resection.
Correct.
So there are some questions on YouTube as well. I just got a message. There is this question by Akshay Nair where he's asking whether open sky silicone sling versus closed technique in Marcus gun won't suturing the sling to the tarsus add more stability. So any remarks to that, Murthy sir or Usha Singh ma'am?
Dr. Adi, there's some background noise coming.
Yeah.
So there's
that is because he has got two devices logged in.
I have just muted that sling, but the question is by Akshay Nair on YouTube. He is asking whether you prefer the open sky silicone sling technique versus a closed loop technique, especially since opening up the eyelid crease, you can stabilize the sling to the tarsus. Does it add more stability, especially in cases of severe Marcus gun jaw winking?
Is that question to me, Adit?
It's a question to the panelists, so anyone can take the question now.
Well, I prefer not doing surgery for Marcus gun, because if it's mild, you just leave it. If it's very severe, then you have to convince the patient for excising the and I don't feel convinced about this excising the LPS, though I have done in the past. In my early days, I have excised. Instead of holding with a clamp, I'd put a hook much just below, in the superior orbit. I pass my hook and hook the entire muscle and I cut it. Okay, but then it has to be followed up with a sling surgery, but I don't like it, because I don't think the patients are that happy. I always feel it's better to have a natural movement, and they could just mask it with the, camouflage it with your glasses and other things. So I try to convince them not to get it done. Okay. Unless it's very mild Marcus gun, then I go ahead with either Fascinella or I do LPS. So that's the only. So at the very beginning, when I'm counseling them, I make sure what they want. So I ask them, what is the thing which disturbs you most? Is it the Marcus gun or the PTOSIS? So then patient does come out with the reply, you will say Marcus gun is all right, that little bit movement, while eating, but this droopy lid is much more disturbing. So that's the time you just assess and you take a decision whether to go ahead for surgery or not. I have seen results of Marcus gun LPS resection and with the sling surgery. I don't think they look natural. You get a better natural look with the
otherwise.
Yeah, I end up getting a lot of children with Marcus Gunn, and all of the parents insist on getting surgery done. So it's a very big problem. But invariably, I convince them not to get surgery done in early childhood, ask them always to follow up and come back later in life. As regards the question that Akshay was asking, so if you've done an open technique, then definitely I'll suture the sling to the tarsal plate. But as you said, I avoid this kind of levator excision. I invariably do a levator resection. When I do the resection, I properly cauterize whatever I feel the cut edges of the levator. It gives me a reasonably good amount of correction of the Marcus Gunn. It never goes away completely. It is always present. So if it was maybe 4 or 5 millimeters, it becomes about 1 or 2 millimeters, which is okay with the patient because I already have told them that some amount will remain. So it comes in the acceptable limits. The sclera is no longer seen superiorly. So patient accepts it. So I invariably do a levator excision, no, a levator resection, not an excision. That is my preferred technique.
Ramesh, one question to you. How frequently do you see amblyopia or refractive errors in patients with Marcus Gunn phenomena?
Very rarely. I see very frequently Marcus Gunn children, but very rarely I'm seeing amblyopia in them.
So you think it has a kind of a protective effect? It takes away the risk of amblyopia?
Yes,
because
I
they
think
keep
so,
opening the...
Yes, definitely mentioned. Yes. Many ptosis cases, somehow I don't see amblyopia very frequently. I see more amblyopia in the squint and the ptosis.
I read some notes by Dr. From Shankar Netralaya by Dr.
Nirmala Subramaniam.
No.
Meenakshi.
Meenakshi, ma'am.
No, not Meenakshi.
Sumita.
Anyway, what is it about?
The Bengali girl with curly hair.
Bipasha
Mukherjee. So she was trying to see whether every ptosis is associated with the amblyopia and refractive errors. And she just found that the surgeons are very careful in selecting their cases before taking up for surgery. I could not get the entire gist of her paper, but that's all. I mean, that's what she said, that not every ptosis case will have, amblyopia. That's what she was trying to say. I think we need to look more closely at our cases. And
I think this was a very fruitful discussion. I hope all the audience.
Absolutely. Very nice. Madam, your question regarding the scalpel vis-a-vis radio frequency, I think I asked Dr. Santosh about it. He told me that we do the cutting simultaneously, cauterization also, it becomes a bloodless field. So we are more comfortable with it. But as you rightly said, it might go haywire a little here and there.
They are comfortable with.
Yeah.
Only thing, when we are giving the incision with this radio frequency, the tip is very small.
Yeah.
And you're holding, and to give it in a straight line, maybe he's very experienced with that by now. So your hand might shake and the incision may not be absolutely curvy linear, it may just run off on the sides here and there. And also the
depth, the way you have intended, it might just run off haywire.
Yeah,
that's right.
So with a blade, I'm very comfortable. I'm very firm and very sure what I'm going to give.
Correct.
With the radio frequency, that certainty is not there. So it's whoever's experienced, I suppose.
Nice. So are there any more questions on the YouTube or Facebook?
There's only one question where a person has asked, when do we remove the frost suture? Personally, I usually remove it on the 5th or the 7th day after the surgery, whenever I use it. With experience, I've reduced the uses of frost suture. I use it for very minimal, limited indications, especially in pediatric age group, because you can't take them under anesthesia again. But 5th to 7th day is a good time to remove the frost suture. Apart from that, there are no more questions here. At least
I removed the frost suture on the 2nd day.
Okay.
Almost all my patients.
Decided just now. Preferred practice. Hello. Can you hear me?
Yes, we can hear you.
Yes, you're audible.
Yeah. Regarding the preferred practice, we had discussed it about preferred practice patterns. What Santosh before he left, he told me that was for the preferred practice patterns, which the American Academy follows it very closely, it's evidence-based. So we have just altered it to preferred practice, clinical guidelines mainly. So that is how it is. So is it okay, or we need to remodify or add something? Just your view, and Ramesh, and of course Adit, yours also, before
So
we
we
set
can
up.
name it preferred clinical practice.
Yeah.
So
So
neither
that is
is
exactly the way we
guidelines
are going
nor
to
is it
come up with.
consensus or anything. It's just preferred clinical practice something. So name should be very non-committal, which means we are not committing to any research.
Non-controversial.
Non-controversial.
Correct.
Because if you
Correct.
go to collect
Madam,
evidence,
what
means
is your
it's
view? अच्छा बोल रमेश बोल दे पहले
so
sorry.
if you have to take evidence, वो बहुत बड़ा task हो जाएगा. mammoth task.
I know.
होगा ही नहीं. We have to think carefully what is easy and practical.
Quite right. Madam, your view?
I agree with Dr. Ramesh because in PTOSIS, there's a lot of variation of opinions, and there are so many ways of doing anything. And I don't know whether we can go by the American way, because here each one has their own technique and what is available in their institutes, and how they have learned from where. I think so. That's
this is the first of the series. So what rightly Ramesh said is, instead of the preferred practice patterns or guidelines, preferred clinical practice.
Yes.
That would be a better word to fit in, is what the way I think Dr. Santosh Unawar has covered. And I think what you rightly said, there are differing ways of doing by a different person. It's well customized. And so we might not be able to label it at this way. Being the first of the episodes where we are starting this series, that's why I wanted your view. Adit, what do you say?
I agree, sir. I agree. It should be preferred clinical practice guidelines.
Because I think there's one more reason, because at the end of it, PTOSIS surgery is an unpredictable surgery.
Yes.
So we have to perfect it by our own experience and form our own nomograms. And so it is very much dependent on the surgeon.
Quite right. So as a concluding remark, thank you very much, ma'am. Of course, Santosh has already left, so I have thanked him. And very much our own in-house consultant, Dr. Ramesh Murthy, and our star moderator today, Dr. Adit. He has conducted it so nicely. And my close friend, Dr. Rajesh Joshi and Rajiv Mudra, to be part of the show, and all the expert audience who have been there with us. I think being the first of the series, we are going to still fine-tune it better and come up with, over a period of my tenure, another 9 or 10 of this series is going to come, not only on oculoplasty, but on different eye subjects. We are going to take it. So thanks for inaugurating this session, Usha ma'am, to grace this occasion. And Ramesh, you too, and Adit.
Thanks to all the MOS members.
Thank you so much, Taswala sir. You did the task of getting everyone together. That is the most difficult.
Yes.
And obviously,
I wanted it. I want more of it, and a little different way, something novel which people have not done, rather than the run of the mill what we are having right, left, and center. Being webinars are too often, so some novel subject and the way what people really require is what is required. So I think the Endor people want, Endor people want to run a video report.
Sir also.
Yeah, and after that, Rajesh will give you a vote of thanks.
For sitting
tell me. Yeah. You also concluded, I think, Adit. Whatever you want to put it across.
Dr. Rajesh Joshi sir should give the vote.
Yeah, Rajesh.
Yeah, I think
vote of thanks for you and a video of Endor people.
Ashwin.
Usually, before the vote of thanks, we have the Endor video. Sayyid Saab, yeah. Yes, Yes, Rajesh. Over to you.
I think every PTOSIS case is different and teaches you something. The essence of today's discussion is proper preoperative evaluation, counseling before you take the patient for correction, and follow-up for adjustment either for overcorrection or undercorrection are crucial for perfect outcome in ptosis cases. I thank Dr. Santosh for sparing his valuable time and for perfect practice guidelines for ptosis. They will be useful for everyone, maybe resident or practicing ophthalmologist. Thank you, Usha Madam, for sparing your valuable time and guiding us. Dr. Ramesh for agreeing to be panelist and highlighting on various aspects of ptosis. Thanks, Dr. Adit, for conducting it so well and lively. I'm also thankful to all those who have joined on virtual platform for today's webinar and also Intod for their technical support. Thank you so much. And have a good night and
Thank
great
you.
weekend.
Thank you, everyone. Good night.
Thank you.
Yeah, good night and great.
Thank you very much.
weekend
Bye.
also.
Take care.
मजा आ गई.
So requesting you all to please stay back. We
Yeah,
have a
just a gallery review short